This is a recording of Chapter 19, Non-Aseptic Technique, and this chapter begins in your patient care book on page 229. When we talk about non-aseptic technique, we are typically referencing things that patients have that don't require sterile technique. So these would be things like NG tubes, male urinals, bedpans, enemas, colostomies, things along those lines. So a lot of times with these patients that have these items in place or require the use of these items, typically these patients are very ill. They've either gone through some type of trauma or they're in a lot of discomfort. They could just have really bad GI issues as well. So with that being said, it's imperative that we exercise the highest degree of technical skill, that we utilize our experience, and that we understand non-aseptic technique, so that we can make the patient feel comfortable and understand that it's okay that they have these, that they require this equipment and that they have these issues, because a lot of times these patients are embarrassed by the issues that they have. These exams, things that they have to use are not comfortable. So it's on us to make the patient feel comfortable and to recognize that when we approach very matter-of-fact attitude, that we're not startled by anything that they require the use of or any exams that we have to perform, that we just make them feel as comfortable as we possibly can, because they already have enough issue going on without us adding to that. When we look at non-aseptic technique, again, these patients are typically embarrassed and very self-conscious. They are either in that situation because of injury, they're in a lot of discomfort typically, or they could be very ill with GI issues. These items require special non-sterile procedures and techniques to be employed. Typically, we're talking about tubes or catheters, lines placed into the digestive tract. You're dealing with body waste or excrement, bowel movements, whether they come through a colostomy, meaning that they're exiting the patient through the abdomen and not the normal route, or it is possible that we have to deal with defecation via the normal route and we have to assist them using a bedpan or something along those lines. And enemas, for not only cleansing enemas, but contrast exam enemas are something that are part of our daily routine as well. When we look at NG tubes, these start off on page 231. 230, 231. NG tubes are typically plastic or rubber tubes that get inserted through the patient's nasopharynx, and they go all the way down to their stomach. And typically they are three distinct uses for an NG tube. They can be used to administer medication to the patient, either when they're unable or it's better for them to put it directly into their stomach because they're typically not able to swallow or they have GI issues. It can be used to decompress the stomach from fluids or gas that might be present, either from trauma or obstruction. And also it can be used to feed the patient short term. When we talk about NG tubes, when it goes to the next slide, these patients typically are in some amount of discomfort because of that tube being placed in their nose and going all the way down to the stomach. It is not a comfortable tube to have in place. They typically don't like it moved or lodged in any way, shape, or form. They're very mindful to tell you that they have that so that you are extra careful not to do anything to disrupt NG tube, because they usually do not want to go through having it put back in. We have to prevent accidental withdrawal of that tube after it's been inserted. Make sure that the patient doesn't grab the tube. You want to make sure that if they're not completely aware of their surroundings, or maybe they're not completely present, then that they're not grabbing in that tube and trying to pull it out because of the discomfort involved. Typically, do not put these tubes in, but a nurse or a physician is actually the one that inserts the NG tube. What we might do with these patients, though, is typically they will use an X-ray to confirm it's in the proper place. So just like with all the other tubes and lines that we've talked about, it typically has a thin strip of metal on this tube, so that you can image and see exactly where the end or the tip of that tube is. So we can either use fluoroscopy to confirm placement, or you might actually even take a portable image of the patient to confirm that it is in the proper place. When we have patients that have NG tubes, sometimes it's important for them to come to the department. And in order for them to come to the department, if they're having that NG tube because of gastric decompression, meaning that they're pulling fluid or gas out of the patient, that requires them to be on suction. And typically when they're on suction in their room, they're hooked up to wall suction. But if they have to come to the department, then have to make sure that there's an order that allows their suction to be halted temporarily, so that we can hook them up to portable suction units and wheel this along with the patient down to the department. And then we would rehook them to our wall suction in the department, continue the exam, and then hook them up to this portable suction unit to return them to their floor. Okay, so typically when that is the case, we have to confirm that there's an order allowing for the transfer and interruption of the suction. And you also want to make note of how long the interruption lasted and make sure that that information gets on the chart. When we transport a patient with an NG tube, suction has to be reestablished once we're in the department, assuming the patient was allowed to be disconnected for that short amount of time. So if they were allowed to be disconnected for a short period of time, it is possible we wouldn't use the portable suction. We could just disconnect them for the time frame to get them from the floor down to the department. Or if the interruption was not to take place and they had to be transported, then we would have to hook them up to that portable suction unit and bring them down. Next, we'll talk about urinals, and this is found on page 232. Now, this particular urinal is a male urinal, meaning that this is used for male patients, typically that are ambulatory, meaning that they're able to sit up, they're able to move around on their own, but for whatever reason, they are not allowed to go to the restroom to urinate. So these are given to male ambulatory patients. These are considered disposable, but what I will tell you is they're not typically a single use, meaning we don't use them one time and then throw them away, but it's considered single patient use. So once a patient urinates into this, we would have to mark how much urine content was in it if they were tracking their output. You would want to make note of how much urine was in that, and then typically you would take that into the restroom, dump the contents into the toilet, and rinse this plastic urinal out with cold water. A lot of times in the hospital, sitting right over the toilet is a type of faucet that allows for that to be done, allows for it to be rinsed out. Notice there's a cap on there as well, so that you could seal that in case you had to transport it somewhere it would not spill. But it has a handle on here where the patient can hold on to that, and then a male patient is typically able to urinate because of its design when they're lying on their back or lying supine, when they're lying on their side, either their right or left side, or when they're in a Fowler position, which means a typical position of a stretcher where the patient is seated with their head above their feet. Typically, we can also refer to that as semi-erect. So that particular urinal can be used for male ambulatory patients. And the biggest thing, you want to try and give the patient privacy if at all possible, whether that means pulling a curtain, stepping out of the room for just a few minutes, but something to provide them privacy when they use that. Okay, it is possible a patient might require assistance with that. If that's the case, make sure you put gloves on before you hand the patient the urinal. Even if you don't intend to help them, I would still have gloves on when you hand it to them. And then when they're finished, you can keep those same gloves to and dispose of the urine. Again, make sure that if it's being done for output, if they're measuring output, make sure you know how much was in there before you dump the contents. So you're going to confirm the volume if output's being tracked. Once you dump it and rinse that urinal out and place it where the patient can gain access to it if they need it again, you want to then take off your gloves and wash your hands. And you also want to provide for the patient to be able to wash their hands as well, whether you give them a little basin with water and a washcloth. Maybe you give them hand sanitizer, moist towelette for cleansing, but you basically want to provide them something that allows them to wash their hands since they just urinated into that urinal. If there are female urination devices, sometimes they will have those which allows the female to stand up to urinate. If I'm being honest, I've not seen any in the medical field so far. I do know they make them, but typically females tend to urinate in a bedpan still. But if they did have the capability to have the upright urinals for a female patient, that would be something that we could use. The bedpans are on page 233. Patients typically are using a bedpan if they're not allowed to get up and go to the restroom. The other thing that I can tell you is there are times that patients can have what's called a bedside commode, where it's literally a toilet that is beside their stretcher or beside their bed in the room, so that they might not be able to go into the room to use the toilet, but they can have the bedside commode. That is always better for the patient, I feel like, versus these bedpans. These bedpans are used for defecation and urination. If it's a female patient, then she typically is using a bedpan for both, to urinate and to defecate in. If it's a male patient, they're going to use the urinal to urinate in, but they'll use these for defecation. And honestly, there are two separate types, but regardless of which one you use, whether it's the standard or the fracture pan, which I'll tell you about in just a minute, the volume that they can hold is typically not very much. You want to be mindful of that, because typically for an adult, it doesn't always hold the volume that an adult patient would be able to excrete. These two types, this is called a standard bedpan. It is on page 233. Typically, this bedpan is about 2 inches high all the way around. Okay, fairly steep to get underneath a patient. This is called a fracture bedpan, and the fracture bedpan has a graduation in height, meaning down here it's probably about 1/4 of an inch in thickness, and then it graduates to about 2 inches high. And these are typically used when a patient has a fractured hip, so that they don't have to raise that fractured hip as much to get the bedpan underneath them, and it's a little bit more comfortable for them to relieve themselves. Anytime you're going to give a patient a bedpan or take the bedpan out, make absolutely sure that you wash your hands and put on gloves. Okay, you want to do that both before and after you remove the bedpan. Again, try and respect the patient's privacy and comfort as much as possible. And even though there are the two different designs, the standard and the fracture, recognize that, again, they are one patient use. If it's a female and she only urinates in those, then you could do the same premise where you dump it out and then you rinse it with water, and it could be reused for urination. But if a patient defecates in this, it is absolutely not reused. It is thrown out. There are too many diseases that are transmitted through fecal material, so we don't want to be trying to dump feces out of these and clean them. Urine, we can dump it and rinse these out. That's perfectly fine because urine is sterile when it comes out. Feces is not sterile by any way, shape, or form. So if a patient defecates in these, they are immediately disposed of. If they urinate, then you can rinse it out and reuse it. But again, it's just single patient use for urination. It's a one-time use for defecation. When we look at the fracture bedpan, this is a better image of it. It starts out very thin down at the tapered end, and then it raises in thickness. But if the patient has a fractured hip, this is much easier to get underneath the patient because it has that wedge-shaped design. And what it does is allow a patient with a broken hip or injury to the hip only to have to elevate a slight amount to fit on that pan. And there's also a little handle right here. You can kind of make that out so that it's easier to slide out from underneath the patient. All right, the colon. There are times that we have to image the colon. They do reference that the barium contrast colon exams are being replaced in many cases by other studies. So we're not always doing the barium enema like we used to do. Now they can do colonoscopies on the patient where they put the endoscope inside the patient and look at the entire colon if possible to see what's going on. And with this exam, the patient is, they're not completely asleep, but they really don't remember anything once they wake up. They're put to sleep. If you needed them to roll over or do something, they could absolutely do it, but they are not completely out for that procedure. Virtual colonoscopy is pretty much a CT where they image the colon with the CAT scan and then they reconstruct it into a 3D model. So it simulates a colonoscopy, but the only thing the patient has to do is lie there and have their CT done. A sigmoidoscopy is very similar to a colonoscopy, except that they're only using, they're only looking at the very last portion of the large intestine, which is the sigmoid colon and the rectum with that exam, nothing else. And last, the one that we tend to do the most often is a barium enema, typically performed in the radiology department with contrast material to image the colon so that the radiologist can make a diagnosis. Now, with all those exams, it requires an absolute clean large intestine. So there is a colon preparation involved. Now this is probably the worst part of the exam because it's either a 1 or a 2-day prep, and there's no relief from a 1-day prep. Typically what happens is they take everything that they would do in 2 days and they combine it so that you're doing it all the same day. So a little bit rougher on the patient as far as getting through that. I'd much rather have a 2-day prep if I had to have any of those exams. As far as the prep, you have to work preparing the patient mentally in order to have that. You have to express to them the importance of having their large intestine completely cleaned out so that when the physician is in there looking, whether it be with the scope or with the fluoroscopic unit, looking at the internal portion of the intestine, if there's any fecal material in the way, that would be near impossible to do. So the patient has to understand that they have to be completely cleaned out in order for this to be effective. You always want to make sure the patient has the phone number of the facility in case they have any questions regarding their prep. They have someone to contact. Typically, this colon prep is used to cleanse the bowel and promote defecation, and it's given to the patients so that they can do this on an outpatient basis, meaning they take it home with them, they read the instructions, they make sure they know what they're doing, and then typically 1 or 2 days prior to their exam at a specific time, their physician tells them to begin that prep, okay? And like I said, it is required for any contrast enema exam and endoscopies because you cannot have any retained fecal material in the large intestine for those exams. What does a colon prep involve? Typically, when a patient is going through a colon prep, there are things like stool softeners are given. It always includes some type of dietary restriction, purgation, meaning they take laxatives to promote defecation. And the biggest factor of all is hydration. The patient has to drink plenty of clear liquids 24 hours prior to the procedure, because what happens is that the barium tends to dry them out. If they dry out too much, then that barium can harden like cement in there. So we always try and express to the patient that out of everything they're doing, the most important aspect is that they have to remain well hydrated for this procedure. It helps not only maintain their body fluid, but their blood pressure as well. Different types of cleansing enemas. Again, these are not typically something that we give to a patient, but at times if they were an inpatient and they happen to be having GI issues, then they could provide some of these types of cleansing enemas to the patient to help relieve some of that constipation that they might be experiencing. So there's tap water enemas, fleet enemas, saline enemas, which are very safe because it mimics our body fluid being the saline, so the body tends to handle that a little bit better. There's oil retention enemas and soap suds enemas. So it's completely dependent on what your particular doctor wants as to what kind of prep you have. Barium enemas are given to patients to diagnose pathologies, polyps, diverticulum, to name a few, to rule out colon cancer, an obstruction, an adhesion, things like that. So we use a barium enema exam in order to diagnose those conditions or those pathologies. The barium enema catheter can have a plain tip or an inflatable cuff, which is a retention tip, and we'll look at those in just a few minutes. I'll point out the difference between the two. But once the tip is inserted, assuming we use a retention cuff, which is 99% of the time what we use, once that tip gets inserted into the rectum, we put in one puff of air to help the patient hold on to that cuff and to not voluntarily push it out. We use what is called barium, which is our contrast agent. Barium has a high atomic number. It's actually atomic number 56, which is found on the periodic table of elements. So barium is number 56, and it can come in some different forms. It can come in pre-mixed form. This would be where it's already mixed up and you just shake it. Or it can come in powder form where you mix it to the consistency the radiologist wants and move forward from there. This is popular. It's one of the only contrasts we use for enteric studies if bowel perforation is not suspected, and we'll talk about that in just a couple minutes as well. You can see how this barium has a pink label. Typically, a pink label implies that it's thin barium, meaning the ratio of mixture is 1:1, which is typically 1 part water to 1 part barium. If it had a green label, it would be considered thick barium, and typically that is 3 to 4 parts barium and 1 part water. So it's completely dependent on how the radiologist likes his contrast mixed as to what we do, or it is possible that we just always go with the standard pre-mixed solution. If it's single contrast, then we typically use the thin barium, and if it's double contrast, we use the thick so that it actually sticks to the mucosal wall. Barium does come in a prepared, pre-packaged powder, and then when that is mixed with water, it creates what's called a colloidal suspension. Okay, that's where the radiologist would tell you how thin or how thick they want you to make it. Typically, the enema bag, now this says up to 30 inches above the table. But I would tell you that we typically do not exceed 24 inches above the table for any reason unless the radiologist directs us to do so. If we are not told to do that, then I would not go more than 2 feet above the table. The different types of tips that we have, these are actually on page 236. Okay, this picture is on page 236, but I'm actually going to move forward and show you a better picture of what we actually use. Okay, this is called a single contrast retention tip. Okay, how do I know it's single contrast? Because notice right here, it only has one port off the side. So one, I always think single. It has a retention balloon right here that gets inflated through this tube. Okay, they insert that, once they insert that tip and they inflate that cuff, then this is just for single contrast. The double contrast, you can see there's one port right here which attaches to that skinny tubing, and then you can't really see it, but you can tell there's something else that comes off that attaches to this blue line, and that is actually considered a double contrast retention cuff. So single contrast, they use one contrast media, which is typically a positive contrast media. And the most common positive contrast media that we use is barium. When it's a double contrast study, it means we use two types of contrast. One is positive, one is negative. So the positive is typically barium, and the negative is typically air. Okay, so again, this tube right here, same that's on a single, that will inflate the retention cuff, which when it's inflated, you can see how the balloon looks. And we are actually allowed to give one puff of it, which is about this much, when we insert the enema tip prior to the radiologist coming in the room. There are times that they have to inflate that even more. And if that's the case, it is not done unless it is done under fluoro. So if you put it in once and the patient is continuing to push that out, then you would let the radiologist know that one puff is really not cutting it and that they need to put more air in. And then they'll put that in, but watch under fluoro to make sure that there's no underlying issue or perforation. When we look at a single contrast enema, it tends to use more barium than a double. We use approximately 2,500 cc's or 2,500 milliliters of barium. Cc's and milliliters are the same amount of contrast used. They just measure different volumes. So 2,500 cc's or 2,500 milliliters is what we use on a single contrast BE. Typically, when you put the barium in the patient, you put the barium in according to the radiologist's direction. You and or the radiologist take some images of the patient as they're rolling around, coating different parts of the intestine. And then at some point, they drain the excess barium back into the bag. And then we let the patient eventually get up and go into the restroom and try and empty as much as they can. And then usually we take what's called a post-evac image, which is after they've gone in the restroom, we image to see how well everything empties. A double contrast enema tends to be used for polyps, which is an inward pouching of the intestine. It's typically a precancerous condition, and they're usually found in the ascending and descending colon. A lot of times patients with a history of colorectal cancer will have a double contrast enema. Anytime there's rectal bleeding, they'll usually call for double contrast because double contrast is very good for outlining the mucosa of the colon. And again, it uses two contrasts, positive and a negative. So the barium is the positive and the air is the negative. Typically on a double contrast enema, the patient will start off prone, they'll put the barium in, and they will actually fluoro that patient and fill the intestine, and that takes approximately 1,500 to 2,000 cc's, and they kind of the patient around to coat the different portions of the intestine so that they can get images of that, because now it's not only full with barium sticking to the wall of the intestine, but it's spread apart by large amounts of air. As far as what we use, this is a single contrast kit, meaning we have just one bag that holds the barium tubing, and this would connect to the enema tip. And then the double contrast kit, same type of bag to hold the barium, but notice this bulb syringe is also attached to the enema tip. So that is how we get the large amounts of air in there. So this tubing delivers the barium at the radiologist's discretion. This one delivers air. So double contrast, single contrast. 2,500 cc's, 1,500 to 2,000 cc's. Positive contrast only, positive and negative contrast. Now, I borrowed this slide because I really liked it from another presentation, but it kind of outlines the difference between a radiolucent contrast, which is typically your negative contrast agent. X-rays easily penetrate these types of contrast. These areas appear black on film. It's considered a negative contrast media. Typically, you're talking about air or gas. What it can do as far as complications, it can create emboli, which are air pockets in the blood vessels. But typically, where we're using it, we're pretty safe. The radiopaque contrast media is positive. It tends to absorb the X-rays, so the areas that are radiopaque appear white on film. And your positive contrast agents are your barium, which is number 56, and your iodine, which is number 53. Okay? And both positive and negative can be used in the same study, and that is called a double contrast study. Some patient concerns, you have to remind the patient that they need to keep that enema tip in their rectum. That's why we use the inflatable cuffs. You try and get them to breathe in their nose and out their mouth to relax their abdominal muscles. They can experience cramping. That is very normal. That breathing does help with the cramping. So does trying to take their mind off the exam. But if the cramping is too severe, they give the patient an injection of what's called glucagon, as long as they're not diabetic, and that is a smooth muscle relaxer that helps stop the cramping. Some considerations for barium enema. They're not doing as many exams now because they can order other studies like CTs, colonoscopies, so the number of exams that we do has decreased. Patient education and communication is vital to the success of these exams. If you're going to remove, or when you're going to remove the retention tip from the patient, make sure you deflate the balloon first. And we're going to talk about this in just a second, but if they suspect perforation of the bowel, we do not use barium. We actually use a water-soluble iodinated contrast, and iodine is number 53, and that is the only acceptable contrast to use. There are 3 contraindications to barium use, or 3 reasons why we don't use barium, and that is if the patient has a possible obstruction, a possible perforation, or they are going to have, or they had surgery within the last 48 hours or the next upcoming 48 hours. If any of these 3 conditions exist, then we don't use barium. We use the water-soluble iodinated contrast. Some considerations about a barium enema: it can cause the patient to experience dehydration. Their stools will typically appear white or gray in color until they evacuate all of the barium. It is important to stress to the patient that they need to defecate to remove that residual barium, and they have to increase their fluid intake, and that comes into play when we give them our post-exam instructions. This is the same no matter what they have the barium for, whether it's a BE, an upper GI, an esophagram. These instructions never change. We tell them, drink 8 to 10 glasses of water in addition to what you normally drink until your stool returns to normal color. Okay? You want to make sure that the patient understands the importance of their drinking water. At times, we also have to deal with colostomy patients, and these exams are described on page 239. You want to be sensitive to these patients because it is a complete lifestyle change for them. Most of these patients have had previous cancer, colon cancer surgery prior. Wound infection is the biggest thing we worry about. The contrast is actually administered through the patient's stoma. They usually have a dressing over that, and we take images of these patients. Typically, it's you and the radiologist involved in this exam along with the patient. So we have to be very mindful of the sensitivity of these patients and what they're going through. In conclusion, non-aseptic procedures typically involve exams of the GI tract. All those things that we discussed are part of our daily routine practice and things that we absolutely do and take part in. We may assist in inserting an NG tube, and sometimes we are responsible to remove that tube. Before we transport any patients with an NG tube, we want to make sure that they're allowed to have their suction disrupted if that's the reason they have it. Barium enemas can be single or double contrast. We do utilize cleansing enemas to prep the patient, and patients with colostomies present a unique circumstance, and we have to be mindful of how we treat those patients. That concludes this chapter, so if you have any questions or comments or concerns, please be sure to write those down, and I will address them the next time we meet. Thank you so much.